Welcome to Behind the Citgo, where we pull back the curtain on the unseen truth of addiction recovery and talk about things most people never get a chance to see. I'm your host, Josh Torbich. Each week, we're sitting down with people who lived it, led it, and are still learning from it today. This isn't polished, it's real, it's raw, and it's noted in the faith and hope because we do recover. So whether you're in recovery, walking alongside someone who is, or just trying to understand what healing really looks like, you came to the right place. Let's dig in. Hey, what's up, everyone? Welcome back. Another episode of Behind the Citgo. We're really grateful you tuned in with us today. We have a very special guest all the way from up in Supply, North Carolina. You live in Wilmington now, but you came from Supply. Your office is at Novant Supply.
Yep.
We have Christy Spivey with us today. She's the Chief Nursing Officer. That's a real thing and a very busy job. Chief Nursing Officer for Novant Regional.
Novant Health Medical Center.
Novant Health Medical
Novant
Center.
Health Brunswick Medical Center.
Novant Brunswick Health Medical Center. That's perfect. Okay. I wanted to make sure I didn't talk about, because you guys are such a large healthcare system that you have to remind yourself what it looks like as it pools out across these communities. So thank you for being here with us today to have this conversation. So today we're talking about how to avoid the revolving door inside of that ER process. And I know it's something that you've tuned into really keenly over the years of your career as a nurse.
Yep.
Now translating into Novant. Talk to us a little bit about your background, how long you've been doing this, and how you've landed in your current role.
Sure. First of all, thanks again for having me here, and thanks for having Novant Health represented here in the Behind the Citgo podcast. Very excited to be here. But personally, my background as a nurse started in 1994. I went to UNCW. I grew up in Leland and graduated with my bachelor's degree in nursing and started in the emergency department as a bedside nurse. And my career ensued over the next 15 years in emergency and trauma services. And then I moved into leadership roles in emergency services, ran the ERs in the region for several years, along with the emergency management program, the trauma program, and the sexual assault nurse examiners program. And then went on to some other leadership roles. And I have a zigzaggy path that has led me to the chief nursing officer role at Novant Health Brunswick Medical Center now, which is a true pleasure. I've been in my role for a little over a year as the chief nurse, and I gotta say I work with the best people in the world at our medical center, and just glad to be here today.
Yeah, we love the folks that we get to work with too. One of the things from over at Novant, one of the things that we have gotten a chance to talk about since we've been having conversations, your perspective now from the operational day load of working as a nurse, but now overseeing nursing for a large healthcare system, you get to see a lot more how meaningful it is when our other systems work in tandem with Novant. And one of the most recent things what we did was that collective impact day. What does that mean to you as a leader in Novant about understanding that from the perspective that you get to have?
That's a good question. Thank you. So I am familiar with participating in a collective impact model from the work that we did in Wilmington with some of our community partners. So going last week and being with the partners here in Brunswick County was really a special event to me, because I know the power that collective impact model has. And when you bring together people, services, agencies, nonprofits, whoever, stakeholders, who have that common and share that common goal. And in our context, talking about this today is how do we serve and bring access to and bring resources to those who are struggling with substance use disorder? So that's the question in the room, right? And everybody has a part in that. And from a Novant Health standpoint, what do we bring to the table? It's not all about us, just like it's not all about each of those services. It's what do we come together in that common goal to achieve? And then that partnership, ongoing communication, building trust, and then monitoring whatever plan we come up with. And so we definitely have a key place in that model. And, for us, we might be monitoring ED visits, hospitalizations, things like that as part of the effectiveness. But we come to the table with that same common goal to improve just the health of our community by making sure that the services that are needed for that population is there. And we can't do it alone, just like you can't do it alone. So working together, we'll have more power to really make a difference.
You're trying to work across the board with your leaders at Novant on a very specific culture that people get to experience whenever they walk into the emergency room. Can you define at a high level kind of what those goals look like and what you want people to experience and expect when they walk in? What's like the
Yeah.
highest aspiration?
Oh, yeah. So no matter where you gain access in our Novant Health system, our goal is to provide a healthier future and remarkable experiences for our patients. And that looks like an individualized plan of care for anyone who comes in, and then exceeding their experience expectations. That's what we want to create, whether you go to a doctor's office, the emergency department, you're admitted to the hospital, wherever you are accessing our care, that's what we want to provide. And regardless of what you are entering, what type of care you're seeking, we want you to have that experience.
It's a busy place often.
Yep.
Everybody has a job, because what most people forget, you're supposed to use the emergency room when there's this key word involved. It's called emergency, right? So, but there are major responses that are taking place, and oftentimes folks land in there that might not necessarily be in that emergency state.
Mm-hmm.
And some of the impressions that they have is, well, the ER should be perfectly equipped to handle this. Where in reality, they should have followed up with their primary care physician or sought some other service. Does anything come to mind whenever you think about some misconceptions about what problems the ER is supposed to solve for individuals?
Yeah. It's all in the individual's perception and life experience, right? I mean, the ER is open 24 hours a day, and we have a little federal law called EMTALA, Emergency Medical Act and Treatment and Labor Act, and it requires us to see any patient that shows up to an emergency department.
Right.
We have to provide care, and so there's that. And the fundamental role of the emergency department is to provide an emergency medical screening exam by a qualified provider, like a physician or a nurse practitioner or physician's assistant, and provide ongoing stabilization. That's the core role of emergency departments across America. However, because it's convenient, open 24 hours a day, and serves all ages and anything that comes in, it's kind of become the safety net for lots of different things. Oftentimes when folks have unmet social needs, talk about the social drivers of health, where they have unmet needs there, that often complicates their life. And if they have an ongoing chronic disease or maybe struggling with substance use disorder, they may reach crisis, and that's the only place that they can find access at the moment that they need it. So we see that. Then, of course, we see lower acuity patients who probably could seek care somewhere else, urgent care, primary care. But again, the ED is a convenient setting. The ED doesn't have it all. I mean, we really focus on making sure resources are dedicated to those life-saving interventions that we need to address. But we do get to everyone, and we do our absolute best, and we have a phenomenal team to reach each patient where they are. You've got to, in the first moments of meeting someone, you've got to do a quick assessment and understand where they're coming from, so you'll be better equipped to meet whatever needs or expectations they have when they come, whether they're having a heart attack or they're having an anxiety attack. It doesn't matter. We have to be prepared for all of those scenarios, and our team does a great job.
Built for speed in a lot of ways when you think about it, because of the level of urgency that most people who are truly in need of the emergency room are walking in there. When you say that this is identified as a genuine ER need, you got to train your folks to get to it quickly. I know with this version of SUD, this is kind of the highlight of what we're discussing today, that folks often find themselves engaging with the ER because, one, they're suffering through some sort of withdrawal symptoms and they're looking for a quick fix to get them out of that. I have a personal story about that. So don't think less of me. No, I'm joking.
No.
They got myself stuck in one day. I slammed my hand intentionally in a car door. All right. And I did it intentionally because I thought to myself, if I bust up a few fingers, I could step foot inside of the ER and probably get myself something to take the edge off when I was actively going through withdrawals. Yeah. When you're designing a system for speed the way that we kind of design, and those kind of disruptions that are more inside of the lane of social determinants, or somebody who's wrestling with the illness of addiction, needs something that can't be offered necessarily in the ED, your folks have to kind of pivot away from that quick action-packed response and then start to engage with that, which takes a lot more in the case of like a social service. Looks like we know that social service is elongated in their approach. So how do you guys pivot, train, navigate around those circumstances as they can potentially cause disruptions and
Oh,
slowdowns?
that's a good question, and it's very complex. Like I said, if you roll back to the primary role of the emergency department, it is to handle an emergency situation and offer that stabilization. So while you might have presented with your hand hurt, during triage or during the front end of the process, we'll often ask questions that will lead us to more information about you and your situation that conveys there may be more going on here.
Something else is happening.
Yeah, something else is happening.
Yep.
Or to think about this, in our ED at Brunswick Medical Center, we see 40,000 patients a year
Oh
in
my
that little
goodness.
ED.
Is that
And
true?
that is very true. We're growing about 3 to 5% each year with the population growth here. And so they are well practiced in human just quick. It becomes a skill set that emergency department team members have because they interact so much with the public. And then they can ask more questions and dig deeper. And we work with our social workers and case management to identify any resources we might be able to help that person with. So if you come in with a hurt hand, but you have something else going on, or if the patient speaks up, sometimes the patient will say a little something to cue us in, but not actually say it. So you have to be really, emotionally intelligent. You got to be paying attention and understanding what that, again, back to individualized care, understanding that person comes with their unique experiences and background that you got to appreciate and understand so that you can better build an effective plan for them. It's not just the ED. You also see that on the inpatient side too, for those patients that are admitted to the hospital.
Yeah. So, and folks, you got to have your listening ears on.
Yeah.
You got to be paying close attention to what folks are saying. There's this thing that I'm trying to flush out in my mind because it's so complicated to not discourage people from using the emergency department whenever there's truly an emergency. And emergency kind of has like a bell curve to it. It's like different for everybody. Emergency level 2 versus 10, right? But then you're also trying to say, hey, let's not unnecessarily burden the ED. Here's these other resources that can be a lot more proactive and actually more focused on the problem at hand.
Yeah.
And does Novant spend any kind of time trying to educate the public prior to accidentally stepping into the ER when they really needed services that were other aligned or parallel?
Yeah, I mean, we have our community engagement and outreach teams that share information. We have community health workers that go out and work with patients so that they'll know what their options are. We even have a peer counselor who, Sheila, she does a great job, but there's only one of her for us, so she's got a big population to follow. But we work with a lot of partners to understand what the resources are. And, in Brunswick County, they're ever changing and evolving. And so understanding what those are so that we can effectively connect that patient with those resources. And through our outreach and education, trying to get that out there to the public as much as possible. But we can't do that alone. I think, again, back to the collective impact model, if we're partnering with, social services or New Hope Clinic or whoever in Brunswick County, and we're able to get behind them and share their materials or talk about them or, whatever, we're elevating them so more people know about them and they're more apt to understand, that's the appropriate place for me to get my care for this. So it's really a partnership, but we've done flyers, we've done handouts, we've had our primary care offices have handouts in them so that their patients know that, the ED is for this, not that. But really, it's, like I said, it's ease of use. It's 24 hours a day. And when people have a real or perceived concern, it's always there. So it makes it easy.
It makes it the first option that you go dip into. One of the things I think about too is how confusing it is for some people to understand exactly what services are offered from the proper providers. There's a level of education that definitely is effective. But when I think about like even Christian recovery centers, the services that we offer, it's easy for us to get caught up in the presentation of our information and forget that it needs to actually translate to the common person.
Yeah.
We want to use these big words all the time so that we can impress other people about how sophisticated our programs are.
Yeah.
But it's really not helpful to the average person when they're saying, wait a minute, how does any of this speak? Wait, is this the right place for me to go? So there's definitely a layer there that you think to yourself, these more grassroots type of information sharing or these, what I saw here that I thought was so clever, these lunches and learn opportunities that they're doing to really explain what's going on and opportunities like that. Does the emergency department have any focuses that they do to try to bring that information down to the layer that it needs to?
I think the best opportunity for us to do that and what we do is take the information we get from patients that we care for who describe to us their stories and the gaps and the tribulations, if you will, that they've experienced trying to navigate the system. And we hear it over and over. If you are in crisis and crisis will happen any time of day, and trying to get into a program, maybe closed, or maybe I can't get in because I'm not sober and I don't qualify, or maybe I don't have a payer. I mean, there's so many, nobody knows all that unless you, maybe a peer counselor, community health worker, social worker.
I think about like this. I don't even know sometimes. I get a call from a community member and I'm in this field every day and they're like, hey, I got a person who needs help and it's got X, X, X. And I go, oh man, I don't know. I got to find. So I know the average person doesn't stand a chance.
They don't. I know in my career and from through the years in my community, my church community, friends, family members, I'll get a call sometimes and it's like, I've got a cousin, we don't know what to do, we're at our wits' end, where do we go? And you start helping them chip away at what's the situation, what's, all these questions. But they wouldn't know that. They wouldn't know that at all. And when you flip it a little bit and you start thinking about the partners that we work with and engage with to provide services for substance use disorder individuals, we get me-centric, right? We like you said, the materials. Oh, they look great. Well, you know what? If I speak Spanish and I'm new in this country and I'm a woman and I have 4 kids, does this resonate with me? Will I ever see this flyer?
Yeah.
How are we reaching those individuals? And so we need to hear from them to tell us how to do that. And the best are the stories. People, telling us, I tried to get in, but they only take admissions Monday through Friday, 9 to 5. And so learning that and then taking that information back as a group to see what we can do to bridge the gaps.
That's really hard work. Yeah. It has to be really intentional. I'll tell you, us also trying to make sure that there's a level of clarity around how those websites are designed, because that is like everybody has access, large population has access to it in their pockets. And when you watch folks who are trying to figure out, the problem is you're kind of like the best kept secret until you're needed. Mm-hmm. Like for us, the joke, nobody looks for a rehab until unfortunately they need a rehab for whatever reason. And by that point, it's kind of, you're already in the mode of scrambling, trying to figure out what your next option is and trying to learn as you go through that kind of crisis happening. And I know that usually lands into desperation, definitely frustration, folks making some poor pivots through that process. So one of the things that I know that we have tried to focus on is putting a layer out there that's easy to digest. Like even our brochures that we're throwing into places like detoxes or the jail system to make sure the judicial system, they're so easy. It's like got 10 things on there that's like, if you come here, you will get this. We don't have this. Those type of things so that they know exactly what they're looking for. Good. When you talk about these partnerships that you have, one of the things that's been really helpful for us, and I know you guys work with this in some way, but the paramedicine program, right?
Yeah, community paramedics.
Community paramedics. Yeah, will you talk about that for a second?
Yeah, so from New Hanover Regional Medical Center, my time there, I've worked closely with that team. They are fantastic. Yeah. They have one of the best community paramedic programs in the state. Sarah Robinbarg leads that group, and they are amazing. And now Brunswick County, Lyle Johnson, he's the director there that we were talking about this just yesterday. They have a program as well. They currently have 2. They'd like to get some more. But the whole thing with them is really cool because they can deploy them to someone's home for non-emergent types of things and help them with chronic disease management, social issues, connection to resources, same thing we're talking about. And because their scope of practice allows them to do certain things with the patient and in the home under their medical director, license and everything and the protocols, they just have a great ability to prevent unnecessary ED visits, hospitalization, crisis in patients, connecting individuals to resources. They just do an amazing job. I've also worked with community paramedics. I used to oversee the hospital at home program out of New Hanover, and they are our in-home care providers for that. So their scope goes from anything you can imagine. They just do a fantastic job, and they do make an impact with helping individuals in their home, and then getting them to the right resource so that they're not ending up at the hospital.
I'll tell you specifically how they've really helped us when folks are in need but qualify for a social setting version of the detox, the titration process. They've really been phenomenal. They'll come out here oftentimes whenever we can't get in front of our nurse practitioner until Monday or something like that. And they'll come on Saturday and they'll plug right in and make sure the person gets a bed this day, but still has access to the medications that they need for that detox process. It's been a really, it hasn't been around in Brunswick County long. Only maybe it's on its way to its second birthday.
I think so.
A little over a year, I think. So, but that's been a really helpful thing. And you're saying what I thought you would say, like that is one of the key functions. That program helps reduce the unnecessary visits to the ED. Another thing that I think is a phenomenal program that I wanted to see if you were keen on, it's not in our notes, but the process that we were talking about with hospice. I know personally that my dad, most people think when you're on hospice, you have to be like within your last 2 weeks of living. But Lower Cape Fear Hospice has put together a really cool and creative program that saved me from making a lot of trips to the emergency department for my dad in the last years of his life, because they would come see him. So it was almost like a version of that community paramedic program, but with nurse and sometimes a physician even.
It's so funny. Earlier this morning, I was saying to a nurse colleague, I said, wouldn't it be cool if everybody had a model like everyone had a hospice nurse, but it wasn't hospice. My nurse in life is Susie. I've got an issue. Let me just give Susie a call.
Let me call
Susie knows me.
Susie will come here.
Yep, Susie's got, that would be cool because that model works so well. And the goal is, they've got it right. The goal is to keep the patients out of the ER, out of the hospital if not necessary, take care of them at home, and then even take them to the care center if needed. My grandmother, she graduated from hospice a couple of times. I mean, we thought death was kind of close or imminent, but they provided such excellent care and ushered our family through how to care for her at home, including her medications and being available all the time. She never went to the ER. She didn't go in the hospital, and she kept going because it was good care. It was effective care, and that's what effective care looks like. So.
Yeah, my dad graduated from hospice twice.
That's awesome.
Yeah, and I mean, we got years with him that we really would have never thought that we had. But, there is that case, like in his situation, most people don't think like this, but we were taking him to emergency room and they go, there's just, at that point, there's nothing left to do for the stage of life that he was in. Bringing that in care for him not only made it easier for him, but it made it easier for the folks who were keeping up with his whole system of care and stuff. So there are times where, as you try to work within the community, and I know this because we were a chief offender of this, that we create disruptions for the emergency room. So I'm going to tell a story. Actually, it might have been one of the first times that you and I got a chance to engage. And this is, I don't know, maybe a few years ago.
Okay.
Maybe.
Yeah.
So we were having folks discharged from our programs, and they were saying, take me to the emergency room. And we knew there was nothing wrong with them, but at their request, we were saying, well, we can't keep them chained to the furnace here. Okay, we're going to take you to the emergency room. And we were dropping people off at the emergency room and just saying, hey, they asked to go. This is what we were doing for them. So getting a call and saying, hey, what's going on with the folks who are showing up?
Did I do that?
And just and saying, what's going on? I said, oh my goodness, we didn't even, and Tyler and I, we were talking about, we didn't even know it was the folks in the direct care who were just, and they're supposed to say, where would you like to go? If you're discharging our program for Christian recovery centers, it's our policy you don't leave walking. That's more of like the commitment to our neighbors to make sure that somebody's not just hoofing it down the street who just left the rehab program. So we're saying, hey, we're committed to getting you somewhere. Tell us where we can take you. Even if it's to the bus station, we need to get you a ticket or something like that. So some of them were requesting, I'm going to go to the emergency room. We take them up there. Here's the problem. We knew there wasn't anything wrong with them. There wasn't anything going on with them. But that was creating a disruption for the emergency room unnecessarily, where some light coaching from our team down here just to say, what do you need to go to the emergency room for? Instead of saying yes at the beginning, what do you need to go to emergency room? Oh, well, I'm just going to go up there to try to do this or figure out my next step. Oh, well, let us figure out the
Yeah,
next step
yeah.
after the emergency room with you. Help kind of mitigate that place. Do things like that happen
Yeah,
often?
yeah. Well, I mean, sometimes. And first, let me thank you for taking my call a couple years ago, because that, I mean, we didn't really know each other,
No, we
but
didn't.
because you have a spirit of being open to making things better, you listened to what I said and you checked on it, and you're like, we could do this better. And so that's how we learn in that
It
collective
is how we
impact
learn.
model.
Yeah.
It's like I trust that my partner has given me information I can act on, and they see it as my wheelhouse, and it probably is. Then how can you know? So thank you.
Well, it was actually the launching point for a better relationship.
Mm-hmm.
And now we have direct contacts
Yep.
inside of the ER who
That's
are
right.
actively creating a referral the same day for
Yeah,
us.
yeah,
And
absolutely.
we'll travel up there every week and get someone who actually qualifies for our service and dip them right in.
That's great.
Maybe if you would have never called me, that would have never happened. We
We'd
don't know.
eventually get to it, but yeah, that
Yeah.
was one of the things. But no, we see all types of patients. There's a phenomenon that emergency department, it's not unique to us, but probably across America. At 5 o'clock in the afternoon, sometimes you'll get a call that someone's coming from a doctor's office because the doctor's office is closing, and they found that they need more of a workup or something.
Wow.
There's sometimes you'll see something like that, but then maybe it's like a partner who, again, back to what we said earlier, maybe they haven't really thought through what the needs of the population they're serving is. Maybe they need weekend hours, maybe they need extended hours, maybe they need to look at the criteria for serving the population. Maybe it's too tight. Does it serve everybody? And like a bias, like a blind spot, they may not know. That's why it's so important to look for that feedback and from the people we're serving, so that we can improve the service and access for them. We just don't know because we're not them. So but
Yeah.
listening is so important.
And the piece of folks, I know that I found a really good partner in our community whenever they refuse to say not my problem, right? And then kind of drop it from there, because it does take the entire community to really make this thing work and churn the way that it's supposed to. But, while the emergency room is a huge part of that, it's not the whole part of that.
Right.
A very specific place to fill a very specific need that needs all of this other stuff around it to really make it turn for the whole person care and the next focus in life. So a lot of people, I think, and I'm guilty of this myself, we do kind of miss the mark sometimes whenever you say, well, I'm too busy to address that, or, fix that, or not my monkey. That's a really tough place to land, and it doesn't really feed back to a place of well-being for the folks in our community. When individuals, I think, are traveling into the emergency room, a lot of them, especially with the mental health crisis that's happening, mental health all-time high, folks are really struggling in some ways with what I would consider more limited resources. When they step into the emergency room, how does the pathway look for trying to serve somebody that you've kind of determined as a primary mental health problem?
Well, it's we take the first approach, like through our triage process, of assessing the situation, gathering objective and subjective information from the patient, and of course our biometric measures. We're taking vital signs and things like that, so that we can see the whole picture. Because we don't want to miss anything that might be an emergency that is not apparent, on the front end. But if someone comes in their issues just around mental health, then we focus on that. And at Brunswick Medical Center, we don't have psychiatry on site, but we have telepsychiatry. So we can have our ER physician see the patient, and then the telepsychiatrist can see them. And then from there, a disposition is made, and patient's safe to be discharged, or maybe they're not safe to be discharged because they've been determined to have harmful thoughts for themselves or someone else. And then we determine, whether or not they might even need to be IVC'd, which is that legal process that if, it actually requires someone to have treatment and therapy, and to keep them safe. Our job is to keep them safe until they can get to that therapy. The sad thing about it sometimes is while they're waiting, beds for mental health patients, we don't have enough in the state. And so lots of times individuals, unfortunately, will end up boarding in EDs across America. It's not just us. Waiting for a bed to become open for them if they have mental health crisis. the extremes of age, geriatric and pediatric, or patients who have special needs, are the ones who unfortunately wait longer because it's even harder to find those beds across our state or outside of our state. So our team does an excellent job of keeping patients safe, providing safe care, creating a unique environment for those individuals. Imagine a child that's lived in such dysfunction all their life that they're struggling with anxiety, depression, and feelings of wanting to harm themselves, and then they land in the ER. And we're like, they can't go home. Their home life is so unstable. It's just a mess. And actually, we start to provide some structure that perhaps they may not have had at home: a bedtime, bathing, regular feeding times. I mean, it's really fundamental stuff sometimes that you see. And so we're dealing with all those types of things. So, and then we, look to connect that patient with the next best step in their care to keep them safe and so they can improve. But then lots of times, and most of the times, when someone comes in with mental health chief complaint, it's usually not by itself. Mental health and substance abuse or substance use disorder, those come together oftentimes, and then lots of social issues: homelessness, income, housing, affordable housing, all of that. We see single moms, young single moms that are struggling. So rarely does anyone come just straight up mental health. It's usually dual diagnosis or something else, or a chronic disease. We're seeing more of the geriatric population with dementia. And they might even get confused or violent sometimes. And so we're dealing with that. And those are hard to place patients and hard to find placement for them. Sometimes we admit patients that we just can't get a bed for, but they're not appropriate for admission, but there's nowhere for them to go that would be safe. So it's teasing out what the individual need is for that person at the time, and then working with their family, working with the community partners, working with our medical staff to make the best plan possible, whether it's in the ER or in the hospital. But it's pretty complicated.
And time consuming. Like, it's extremely time consuming, especially knowing, oftentimes when they're checking in there, the first response, but it's not the right response for their next step, for the continuation of care. So you are kind of holding pattern until you can get them to land in that next successful step. And that's why I think our pivot, we are really trying to pivot to make sure the people who need to be a part of Christian recovery centers want to be a part of Christian recovery centers. I want to be able to say yes to them within the same hour that's identified. I want to be, that's the key though. Like what we're describing is that's what we do. People need us. People want to come here and participate in the recovery programs. We need to focus on being able to say yes as soon as somebody in there is like, okay.
That's great. Because we know we got to get them while they're hot, right? So I learned years ago from the emergency setting that if that person's in front of you, a warm handoff, or even inviting that community partner to come, if the patient agrees, if they're discharged, use our lobby space, whatever. Get them while they're there, because when they leave, you've lost them, and they go back. And there are, a lot of success stories. I hear a lot of people say, "I was so broken, and I came to the ER, and that was my turning point. I had nowhere else to go. I was in crisis. A lot of them have medical concerns and issues, and you start to address those things and then get them connected, and it was life-changing for them. Sometimes you have to get to that crisis, and it does involve what we can provide in the emergency department or the hospital to get them situated so they can start a recovery.
Yeah, I've seen that too. We have stories down the hallway right now who are fitting in that lane specifically, that the ER was the perfect bridge to get them to a more permanent landing spot. And then when they, get into a community-based program or another resource referral that can kind of continue that road with them, what's key to make sure what we're talking about today, we limit that revolving door. And it is probably making sure that the same commitment, and I think about this often, the same commitment for a warm handoff from Novant or from the emergency room anywhere to that community partner, that community partner verifies the same commitment. That if what we're doing turns out not to be the right fit, then I'm going to make sure I work with that person to find the right fit, the next one, so that it doesn't become the default. Our default in American society today is the emergency room.
Yeah, it is. And I think you're right. I think that instilling that culture,
that's a culture thing.
In our community. And I think we have there's lots of great collaboration in this county. And I think there's so much more we can do. And, but instilling that and showing that example and being open to working with others so that we could build that network that's effective and just increasing the effectiveness of that network as we go and adding stakeholders that we might be missing. And who knows, maybe even developing things that don't exist now that are gaps that we're going to need in the future.
When folks are wrestling with this idea of how they access the proper amount of care, the right version of care, all the things that would go inside of that, I always had these dreams that it would become easier for them to know exactly what they need to put their finger on. And once they determine what their next step looks like, that primary choice that they have is probably a great step, right? Most of them who are trying to step into a better place, they're picking something in their head that's like, okay, I'm going to make my situation better. Once they get engaged with that kind of care and they take that first step, it's discouraging to see them backtrack sometimes. Like, oh, that's not a good step. Don't do that.
Yeah.
But then they have their own choice, so one of the things that's really difficult for us is to watch people who make a decision to leave our program, can't keep them chained to the furnace, into an environment that's less than ideal. And yes, sometimes they choose to discharge into homelessness. It breaks our heart. Yeah. It's really discouraging, but there's no way to keep them, and there's no way to keep them engaged. Some of your folks are really tactful. They have their ways of building these relationships really quickly to make sure there's trust there. And then the folks can kind of say, okay, I'll hang out for a little bit longer and figure this out with them. But it doesn't always work. You'll see them back. Because that's the revolving door part. They've made a poor decision. They've stepped out. They're coming back. Most often they are. What are some of the redesigns that you think we could do to try to make even that process more effective? When somebody's at that turning point where they're ready to make a choice and it's like, oh, please don't make that choice. What are some of those stalls preemptively that you see folks?
Well, there's a couple of angles. One that comes to mind is a process-related angle, right? If we're really smooth and clear on a standard approach to getting them connected quickly, like I mentioned before, partnerships where we know if we have a warm handoff or even I'm calling Josh, he's going to drive over and talk to you now, or we're going to get you a bed at CCRI today. I mean, having processes that support that kind of definitive action is huge. That may not be something we can do in other cases. So building a relationship with that person and building trust through listening and making sure that they know that they can share what they're thinking and trust that someone's going to give them alternatives that are going to be a better choice. But also engaging, again, I go back to peer counselors, community health workers, navigators, individuals who live in that environment, work in that environment, and can advise on what options they have, and that going backwards is not the best and not the only option.
So, and being able to have the relationship with the other organization personally makes it really warm in that process. And oftentimes the folks we serve pick up on that warmth. They see it happening seamlessly.
They can feel it.
They can feel that happening. One of the things that we talked about already was this responsibility of outcomes. What do you think is the key to folks who are really trying to create solutions for our community? Like you would see at the leaders at Novant, Christian Recovery Centers, Coastal Horizons, anybody in our community who's really trying to help people grow into that better place of their life. How do we develop that culture you were talking about of I am just as worried about your outcomes and the folks you're serving as I am about my own? Where does that come from? How does that happen?
Well, I'd like to say it's always internal motivation, but it's not always. So sometimes we have to be motivated by incentives. So we talk in healthcare about value-based care. And so look, we're going to pay you, insurance company, Medicaid, Medicare, whoever, we're going to pay you based on the outcomes you produce. So if you reduce ED visits, then guess what? You get a reward. But if you don't, you don't. So what would that model look like for other agencies, other participants and stakeholders in this ongoing model and work that we're talking about? So rewarding those things that get the outcomes that we want. And again, back to collective impact. If we have a clear goal and we're working together, we have all these disparate grants going on across these groups, right? And we're kind of fighting for the same money sometimes.
Siloed funding resources. Everyone's going after the same pot.
What if we had a clearer collaborative that had expressed goals that were aligned, that were able to take that funding in one bucket and use it more efficiently so we aren't wasting funding? So there's that. But I think it's transparency, really. It's saying, hey, I come to the table, here's what I see that can improve, and here's my goals. But if we achieve my goals, it's also going to benefit you. So how do we work together? I think it's got to be that. I really do.
Yeah, the picture I get is how a lot of times, often, and especially in the nonprofit world, we all approach the table to have a conversation, but everybody's like this with their stuff, covering. Oh, well, don't look at my stuff. Don't talk about my stuff. How rewarding would it be if it's like, hey, these are all of the things that we have to offer, and just pushing them to the table. One of the things that was really difficult for us as a ministry, and it happened a couple of years ago. You were part of a collective impact that was led by UNC. And so we became part of that research project 18 months or so ago that was funded by the North Carolina Collaboratory. And going through that process was a lot scary. And I'll tell you why it was a lot scary. Because you didn't know what an independent person and research team would come in and find as they use their measures to see how successful you were. Now, as the CEO of the ministry, it's my job to make sure the community continues to know that Christian Recovery Centers is doing phenomenal work. But we do that internally. We say, here's our success rate, here's our retention rate, here's how many people we served. And as Christian Recovery Centers, the Christ part, here's how many people accepted Christ, here's how many people, all of the things that we consider important to our service. But then to let them come in. Yeah. And it's almost kind of like that too. That it takes a layer of humility to be able to say, yeah, you're going to find some things that don't look as pretty, but we kind of want to know about those things.
Right. That spirit of continuous improvement. So if you're going to get better and serve better and do better, then it takes sometimes outside eyes to evaluate. And so translating that into my world of work, it'll be consultants. So outside consultants, and, they will uncover things that maybe we were blind to, or maybe we needed to prioritize a little more and get more gain out of it and just refocus things, whether it's improving processes, quality, finances, whatever that is. And that's why we do that. These accrediting bodies that come to our hospitals, Joint Commission, DNV, all of the centers of excellence that we have across Novant Health, we do that because it's a standard. It helps us to be better. And they come in and hold us to certain standards, and that's how you achieve those. And it translates into better patient outcomes. And so translate that back to your work or the collaborative that we're talking about, then having outside eyes helps us to improve that. They'll point out things that will get biased or not even notice because we're inside of it. So it is a healthy process, and it all is in that spirit of continuous improvement.
If somebody thinks that they need to be able to work with you and they think they have a way for either you to help them or them to help you, what do they do to start that kind of process and that conversation? Who should they reach out to?
For me personally?
Yeah, anybody. If they're looking at Novant and they're saying to themselves, wow, I really think that I can help with XYZ in Brunswick County, and this seems to be a shared interest from Novant. I would say when we did that for you, you guys were wide open. Yeah. Hopped on the Zoom call, let's have the conversation, let's see where the synergy takes place. Yeah. Some people might not know that it's that easy just to start a dialogue and exploratory conversation to see if there's any synergy there. Are we sharing this goal together, and how can we work on it together?
Yeah, I welcome anyone reaching out to me via email or phone call or LinkedIn, whatever works, for us to start conversations. And if I'm not the right person in Novant Health, I can help find and navigate to who would be the right person to have a conversation with, and our role, I'm speaking as Novant Health, our role in the community is, again, back to our mission, create a healthier future, bring remarkable experiences to life. That's beyond the walls of the hospital. It's definitely in our community. And a lot of our team members, they live in this community. They worship in the community. Their families are here. So they want excellent outcomes, health outcomes too. And so we're all plugged in and willing to help. And if we aren't the right person or department or whatever, we can find those people in our facility or our system.
Yeah, that's true. They got skin in the game.
Yeah.
Yeah, they want to see this place thrive too. I feel that same way. So I do want to say thank you for being able to help us shepherd into a conversation with you guys, and then even being able to grow and move from how we can both be more effective for our space. So watching that take place is very rewarding, and it's hopeful. Yeah. It makes you hopeful because there's so much bad, that you interact with in these fields, and it's hard to stomach sometimes the idea of man, there's so many things that need addressed, so many problems in our community. Most of the time it overshadows the big wins that we get.
There's a lot of good happening, and we appreciate the partnership. And likewise, I appreciate you and your team and the work and the conversations we've already had. And it is tough. And, our team members see a lot of stuff every day, but they also see a lot of great stuff, great things. And they're just top notch. I mean, they are trained at the highest level to deal with all types of situations. Whether it's fundamental safety issues or high level conversations with patients and their families about end of life issues. I mean, you name it. They're really equipped and prepared, and we do a lot to take care of our team members. We offer mental health resources, physical resources. We have a gym. We have rebates and discounts on health promotion, just all of those things to make sure that, the very fundamental things that our team members need to stay healthy so they can care for our patients and their families is very important. That's one of our priorities is team member health and well-being. We actually just installed at Brunswick Medical Center a pod where you can sit in it, and this clamshell comes down and it has light and music. And so
don't tell them.
So our
don't
team,
tell my team. Look,
they're like,
all of the team just looked up and was like, ooh, they're all busy doing their different things in here, and they just all looked up.
It's wonderful. So a team member can take their break and go in there and just, if you're on a care unit, there's just noise and alarms and call bells going on. It's just a constant stimulation, but you could take a break and go in there for 15 minutes and just regather and get back out there and replenish, So we're looking for cool and innovative things like that to do for our team members.
That is cool. Shh. Don't tell them. Don't tell them what you got.
They want to come see the pod.
I was about to say they might want to come work for you. I won't have anybody left. They're going to come. No, they'll leave. They'll stay working here, Christy, but then they'll go up to Novant on their lunch break and
get in the pod. Yeah.
They're like, do you work here? No, we're one of your partners down the street. We heard there was a pod.
Yeah.
Well, this has been really meaningful. Today, folks, we got a chance to talk again. Christy Spivey, Chief Nursing Officer from our local Novant, and we talked about how to avoid that revolving door. We'll drop a few links inside of the conversation today about resources like to the community paramedic program that we talked about, so you guys can learn more about that. Also, some other initiatives that works directly from the ER that we're familiar with. We'll drop a few things in there. We thank you for tuning in with us today, and we hope to see you next time.